do a quick intro, should we do? I'll introduce me first, if that's all right. My name's Mike. I'm an osteopath and work with the Rock Tape team in the UK. And I've got a special interest in anatomy. That's why I kind of cover all the anatomy sections on these sessions. And we back. How many weeks have we been doing this now, Dan? It's probably about 8 weeks, isn't it? Something like that.
It's approaching that. Yeah, we've got quite a bank of webinars recorded on the PHYSIO channel. I was just looking at them the other day. So yeah, we're stacking them up.
Yeah. So we've got, if they again, I mean that we've done this one in response to some of the suggestions from last week. So if anybody's got any conditions that they want us to cover, and we can help out with any kind of advice, then please let us know in the chat box. So that'll be good. Katie's got her wine. Brilliant.
Yeah, I know. Brilliant.
Great. Dan, do you want to introduce yourself, mate?
Yeah. Hi, everybody. My name's Daniel. I'm a physiotherapist and the education director for Rock Tape UK. I work clinically and I write and produce videos and webinars such as this one with Mike today. And today our topic is, as Mike mentioned, I think, ankylosing spondylitis. So yeah, we're going to get started. Mike's going to start by talking about anatomy, and then I'll chip in when Mike gives me the nod.
Cool. Yeah, thanks, Dan. Right then. Okay, let's get going. So if I'm going to teach this, as we do every week, as if you have never heard of the condition, so assuming that you know nothing. So if you have got experience with the condition, if you've seen people or you've studied it before, then apologies, but we are going to start from the basics. So ankylosing spondylitis is a funny condition. Not very many people have heard about it. Unless they know someone with it, and then obviously you find out a little bit more about it. But basically, ankylosing means fusion, and then spondy is to do with the vertebra of the spine, and then itis is an inflammation. So it's part of the spondyloarthropathies, which Dan will talk about a little bit later. And it's often thought to be linked in with rheumatism and rheumatology, but we're going to have a look at that and actually what it is linked into rather than a rheumatoid factor. So just going to do a little bit of an anatomy recap for everybody, and going to specifically have a look at the sacroiliac joints, the enthesis or the enthesis, however you like to pronounce it, the costovertebral joints, the facet joints, and the spinal ligaments. So I'm just going to have a look at those because these are the areas that are commonly affected by ankylosing spondylitis. So if you have a patient come in, then these are the areas that you may see have been affected by the condition. Let me just switch to this. Here we go. Okay, there we go. Right. Okay. So if we just zoom into the sacroiliac joint first of all, there we go. So we've got your sacrum here, and then the ilia here. So obviously the join there is the sacroiliac joint. If you have a look at it from the back, so that you've got your PSIS around this area here, just there and there, and then the back of the sacroiliac joint just there. Hey Matthias, how you doing? Good to see you again. So I'm just going to add on some ligaments here. So these ligaments here, these are the posterior sacroiliac ligaments. So we've got left and right, and if we switch them around, we can see them on the front as well. So anterior SI ligaments here, and this one here, this runs all the way from the coccyx, and I'll see if I can zoom out there. Yep, there we go. And it runs all the way to the top of the cervicals. Okay, so this is the anterior, because it's on the front of the spine, longitudinal ligament. So it goes all the way up the whole length of the spine. I'm just going to add another layer of connective tissue on here. So these ligaments here are the let's go for this bit first. So this bit here is the transverse process. So this will be the lumbar spine here. So we've got L5, L4, L3, so on. So that's a transverse process of L4 just there. And in between there, we've got the intertransverse ligaments. Okay, so they're in between the transverse processes, and that's why they're called intertransverse. just add another couple of layers on. So we've got the iliolumbar ligaments here as well. So they go from the ilium to the lumbar spine, so the iliac crest up into the lumbar spine just there. And then these ones, just see that green area there. So this is quite deep now into the spine, and we've got the spinous process. If I just turn it there, we've got these lumps on the back of your spine, spinous process, and then the section of spine that joins your spinous process to the transverse process is called the lamina. Okay, so that area in between is the lamina, and that ligament deep to that is called the ligamentum flavum. Okay, so we've got loads of ligaments all around this area. I'm just going to see if we can get another layer in there. Bear with me a second. Cool, right, so let's just see if I can get that one there. Okay, so this bit here, that bit there is called a facet joint. Okay, so where the vertebrae join each other, you've got a superior facet, which will be that one just there, and then the inferior facet would be this one just here. Okay, so where this so this vertebra here is L4, this one here will be L3, so that's the inferior facet of L3, and then the superior facet of L4. So, and these are really important when we come to look at what happens to those areas in a second, when we look at why we get ankylosing spondylitis and what actually happens, because these ligaments in here are all affected by the condition. So, and it usually starts in this region as well, so around the sacrum, and then works its way up the spine. Okay, so we've got the ligaments around the SI, the ligaments around the spine, so the front of the spine, the side, and around the back, and also the capsules around the facet joints as well. And then if we go up a little bit further, we've got a rib here, and then a transverse process just there. And then where that rib joins into that transverse process, we've got costovertebral joints, and there are ligaments in there as well. Okay, so we've got ligaments joining the ribs to the spine, ligaments going all the way up the spine, and also the really thick ligaments that are on the back, or just get to there, on the back of the sacroiliac joint as well. Okay, just a couple of other places I want to recap, and that is just down here. Let's see if I can get him in the right place. There we go, just zoom in there. Okay, so this is the bottom of the heel. So we've got the calcaneus bone just here, so your heel bone, and then this here you should recognize as the plantar fascia. And where the fascia attaches into the heel bone is called the enthesis, and we've also got, or enthesis, and we've also got, we just put some layers on here, pop some muscles on. There we go. Okay, so you hopefully recognize that Achilles tendon just there as well, something that Dan is very familiar with his book. And then if we zoom in here, so where the Achilles attaches into that calcaneus as well, there's where the tendons and the ligaments both attach into the bone, so the covering of the bone is the periosteum, where it weaves into that periosteum is called the enthesis. And those areas as well will get affected with ankylosing spondylitis. Okay, so there's several areas of the body. I'm just going to focus on the musculoskeletal ones in this particular section, but there's loads of areas in the body that are affected by AS. So it doesn't just affect the spine; it affects lots of different regions. So I'm just going to switch back onto these slides a second. Okay, yeah, so we've done sacroiliac joint. Okay, so we had a look at that, the joint between the sacrum and the ilia. The enthesis, so in particular where the Achilles tendon inserts into the calcaneus, and then the plantar fascia inserts into the calcaneus as well. Those are quite common areas for people to have symptoms. The costovertebral joints, so the costals are the ribs, and then where they attach into the vertebra is the costal vertebral joints. We had a look at those. And then the facet joints as well are the joins in between the vertebra below and the vertebra above, towards the posterior aspect of the spine. And then you've got all of the spinal ligaments as well. Okay, so all of these can be affected by this condition in terms of musculoskeletal. There are other things as well, which Dan will cover. So who gets it? Who do we need to look out for in clinic? Well, these are the people we need to look out for. So 1 in 200 of the adult population in the UK will have some kind of axial spine. So the main bit of your spine down the middle, spondyloarthropathy. Okay, easy for me to say. So it's more prevalent than you think. I think anyway. I didn't realize that it was quite so many people, but it does include lots of different types of other conditions as well, not just AS. So there are a number of kind of family of spondyloarthropathies that you can be affected by. It usually affects men. Okay, so men are affected 2 to 3 times more often than women. So when you get in the guys into your clinic, these are the people that we need to look out for. And it also is a condition that affects younger people. Okay, so symptoms usually start in the late teens to early 20s, and the average age of onset is 24. So we usually think of this as kind of like an arthritic condition, and arthritis is usually the elderly population, but this will affect usually young males. Okay, so that late teenage, early 20, that's who we need to look out for. And Dan's gonna have a chat now about why people get it. I'll just pop your slides up, Dan.
Brilliant.
Okay,
Thank you, Mike. So my sound, is it coming through loud and clear?
All good for
Excellent.
me.
So when we look at the etiology, one of the key things is HLA-B27, which stands for human leukocyte antigen. So it's a type of antigen which is detected, as it shows on the screen there, in 80 to 90, and I saw some figures suggesting 95% of ankylosing spondylitis, we'll call them AS patients. But it's also detected in a small proportion of patients without, or people without ankylosing spondylitis, normal people or people with without the condition. So having that antigen in your body and in your bloodstream does not mean that you have ankylosing spondylitis. And also the lack of that antigen in your blood doesn't mean that you don't have ankylosing spondylitis. So again, the specificity of the test is not 100%, as it suggests there on the screen with the 80 to 90% detection rate. What that means in clinic is if you think a patient has ankylosing spondylitis and they have a blood test and they don't have this HLA-B27 antigen, then they could still have ankylosing spondylitis. Therefore, it's a diagnosis by deduction rather than a positive identification of anything. A lot of the diagnosis is to do with excluding other things, and then you're left with a diagnosis of ankylosing spondylitis, which I'll look at more later. But you can't positively detect it with a simple blood test. However, it is highly likely if they have the symptoms plus this HLA-B27. So that's what they will look for with a blood test. They'll look for other factors as well, but this one has the highest specificity for detecting it. So this was interesting in the news today, wasn't it? I hope our sound is better than when this guy was giving an interview today. There was some awful sound in the background. Does anybody know what that sound was? You put up a comment for us in the chat there. It sounded like a child playing a guitar, or then it sounded like somebody in the background who knew the interview was going on and were just trying to disrupt it. But it was awful. You certainly wouldn't get that sound quality from our webinars, Mike. So yeah, I don't know what that was about. Anyway, blame your parents. It's hereditary. That HLA we've just looked at, if you have that antigen in your body, there's a 1 in 2 chance that you'd pass it on to your children as well. So there is a strong genetic hereditary link with ankylosing spondylitis. Therefore, if you have a patient and you have some suspicion, it makes sense to go back there. Danielle said, Let's not go there. Okay,
Yeah,
let's go
yeah.
somewhere
Leave the
else. To the
politics.
next
Yeah,
slide. Oh, who's this, Mike? Mike with a mask. Clinical
yeah.
presentation. So,
I would wear a mask if I could get hold of them.
oh, really? I'll send you one. My mum's knitted a few.
Thank you.
So, a patient comes to see you. Now, the typical presentation, as Mike said, is somebody in their late teens to early 20s, but it can be up into the fourth decade of life as well. However, in those latter years, it's much less likely to be a presentation of ankylosing spondylitis, but don't rule it out. However, it's much more common in the late teens and early 20s, and of course, more common in males, which does present some other issues, which I'll discuss later. Now, the type of presentation, it's likely to be non-traumatic. Of course, they could have done something to their back. They could have fallen off their bike or fallen out of a tree or fallen over. But often the presentation is non-traumatic. And it starts with sacral pain, most typically lower back pain. And it's usually there and it's been persisting for over 3 months, which immediately puts it into that persistent and chronic category. Morning pain lasting longer than 30 minutes. That's one of the key clinical signs. Morning pain is quite common when you have lower back pain, but if it persists for this length of time, then you potentially are looking at something inflammatory, not necessarily ankylosing spondylitis, but at this stage, something inflammatory. If the pain eases with exercise, but then returns again with resting, this is a sign that you've got something inflammatory going on, a sign that it might be the ankylosing spondylitis. Particularly if the stiffness returns when they rest, and therefore the stiffness returns at night as well. As well as a progressive loss of spinal movement as well. Your patients are going to see a gradual reduction in the mobility. And if you're working with a patient over a number of weeks or over a number of months, and you start to see this pattern of morning pain and stiffness that eases with exercise, but also a pattern that is generally worsening. If the patient is not getting better, is generally worsening, and you feel that your standard evidence-based exercise-based rehabilitation is not working, then there may be something systemic going on. There may be something inflammatory going on, and your suspicion, if not before, should certainly be heightened at this stage. Shortness of breath. This comes from the reduced rib cage mobility because those costovertebral joints can be affected by the disease process. So that's another one to look out for, is the link really between respiratory function and the musculoskeletal system, which comes from the rib cage. But it's not just the spine, it's mostly the axial skeleton, but it can involve the hips. I've seen it in the hips on a couple of patients. It can affect the knees. I've never seen it affect the knees. It can affect the shoulders and neck. I've certainly seen it affect the shoulders. And neck pain is very common, so you can never be sure whether it's purely the ankylosing spondylitis that's causing that. And I've seen it also affect tendons, as Mike alluded to. Having bilateral Achilles tendon pain is another telltale sign that fits into that package of diagnosis rather than it being a single thing. Then eyes. We were always taught to ask this question as well about iritis, irritable eyes, which is thought to occur in about 25% of patients with ankylosing spondylitis. But stepping aside from the more physical things, such as the musculoskeletal issues, other factors, these patients can often suffer from fatigue and also suffer from fever, and as a result of these things, low mood and poor sleep, which often correlate as well. So we're seeing here a picture that takes us beyond just having a sore lower back. We're thinking about the how the back pain came on, how long it's been there for, how it responds to certain interventions, but then also looking more holistically at the whole person and seeing how it affects other parts of the body, because it is a systemic condition and one that affects the whole person, lowering their mood and affecting many other parts of their life. So we're going to focus on how you might diagnose it, and that's based on the factors we've just discussed. What happens next is this. A diagnosis of ankylosing spondylitis is determined by 3 areas of investigation. The clinical we've just looked at, and we can be more specific with the clinical. There are some guidelines in place, and there are some diagnostic tools you can use where you look at how much the lumbar spine moves using like a Schober's test, for example, and you look at rib cage expansion based on normal values and look at other spinal ranges of motion as well. So some of those do exist. Then the other side are laboratory tests, blood tests, which we mentioned, looking for the HLA B27 and other inflammatory markers as well. And then imaging, most commonly X-ray and potentially MRI scans as well. On the X-ray, one of the things you'll see if the disease process is going on for some time is ossification. So the ligamentous tissue around the spine starts to ossify, and this condition goes by many different names. I can't remember all of them, but one of them that I can remember is bamboo spine, because the spine starts to ossify. Those ligaments, which Mike just showed you, which encapsulate the spine and wrap around the spine, if you start to get ossification in those soft tissue structures, then the spine starts to look more bamboo-like. So the bamboo spine is one of the signs of more advanced stages of this condition that would show on an X-ray. So an American pioneer has found a cure last week. Oh, perhaps not. There's no cure for this. There's no cure for this condition. There's no cure for a lot of musculoskeletal conditions. As we know, the chronicity of things like back pain and neck pain, even in the absence of inflammatory pathologies, we know that often there's no magic cure and no magic ailment out there, no matter who tells you there might be. So it all comes down to physical management. And we've got our guru there who's going to take us through the physical management. You'll see how many different places I can stick your head, Mike, during our webinars. Conscious that you can also do the same for me. The aims of physical management are these. Yeah, oh wait, you're away next week. I get up to all sorts of mischief. We need to maintain mobility. We need to manage pain. And we know there's many factors to managing pain, not just the physical side. There's the psychological and the social elements as well, which we can only really touch upon today. We need to maintain function. That's just normal daily functions, including, importantly, the ability to continue with schooling and study or continue with work as well. We need to improve posture. Now, I know there's been a lot of talk in the research recently and on social media amongst therapists suggesting that posture is not the cause of all people's pain. Well, when it comes to ankylosing spondylitis, posture returns as a very strong pillar of successful management. If you think about the fact the spine is ossifying, and therefore what can happen is the spine can literally fuse itself, the positions that you spend the majority of your time in will be the positions that the spine decides to set and fuse itself in. They'll be the positions of rest and the position of structure. So your posture and your position with ankylosing spondylitis will become your structural shape. So it pays to make sure that when you are sitting still or standing still or sleeping, that your postures are something that you pay important attention to. So postural education is important. That being said, we don't want to instill this idea of you must sit bolt upright and straight at all times, because a big part of the management is movement. But of course, we can't move all the time. So when we're not moving, posture, it needs to be something that we pay close attention to. Maintaining strength is important as well, for many obvious reasons. But a lot of patients with ankylosing spondylitis will also suffer from poor cardiovascular health. So any measures to maintain or improve cardiovascular health through cardiovascular training would definitely be an important part of the program, as would maintaining respiratory function, which would come from cardiovascular exercise, but also from some more specific training as well, which we'll look at in a moment. So good physical management will also help manage the psychological and social impacts of this condition. The psychological and social impacts are very important, but they're not something that we're going to have time to go into during this webinar, but I think we do or will support them with good management. So I wanted to, rather than go over everything, which would take, probably at least a day, I wanted to just go through a few specific examples. One of the targets of physical management is to try and maintain mobility of the thoracic spine. And one of the reasons for that is not only because it's affected by the ankylosing spondylitis condition, but because of its close working relationship with breathing and with rib cage mechanics. So a good mobile thoracic spine will help the breathing. And also when you do this exercise, as you can see in the picture there, it is expanding the rib cage as well. However, we need to watch out for, and I've got my pen there, lumbar spine hyperextension. And this is a big thing to watch out for. So we're going to need to educate the patient to engage their abdominals and to do some pelvic tilt work rather than just get them stretching over a roller. If they've got a very tight thoracic spine, all that may happen here is they hyperextend their lumbar spine, which just causes them irritation and does nothing for their thoracic spine. Furthermore, if their process is further down the line that their thoracic spine is perhaps very stiff or even fused, then this type of activity is going to have much more limited value than somebody who's in the much earlier stages and still has the ability to extend their thoracic spine. But thoracic extension work is one of the mainstays of early management of ankylosing spondylitis. It's more difficult in patients where that part of their spine is significantly stiffened up, but that needs to go in line with educating that they don't just hyperextend their lumbar spine as well. I think this is a good exercise. I'll just take there we go. I think this is also potentially a good exercise. I say potentially because we need to make sure we're not hyperextending the lumbar spine again, but these dumbbell pullovers really help to expand the chest, and in combination with breathing exercises could be an excellent exercise for rib cage expansion. So we're looking here at thoracic spine, but also rib cage expansion, which is one of the key components of successful physical management of ankylosing spondylitis. Which brings us to breathing. Breathing is one of the key components. We need to look at chest expansion, which we've just touched upon. That could also just be taking deep breaths as well. We've all done that or advised patients to do that, is to take a deep breath as part of our assessment or as part of their rehabilitation. But if you're aware of breathing mechanics, you'll know that taking deep breaths just on their own is not really a good idea, because it can promote too much chest expansion and a lack of diaphragmatic breathing as well. It can cause an irregular breathing pattern. So in conjunction with good chest expansion exercises, we also need to make sure that they're engaging in diaphragmatic, or otherwise known as abdominal breathing, so that they're not routinely expanding their chest and doing that paradoxical type breathing, which is chest based rather than abdominal diaphragmatic based. Chest expansion balanced with breathing mechanics, and then respiratory muscle strength. You'll see my model Rose here has got one of those respiratory trainers. Power Breathe was one of the most famous ones, but you can pick these up for around about £10 now, and they just provide some resistance to inspiration. Not like the asthma testing ones, which you have to exhale into. These are inspiratory trainers. So if this is done correctly, it will help to activate and strengthen the diaphragm, but it needs to be done correctly, because if it's not, then you can cheat and just use all of your accessory muscles, and again, further strengthen those accessory muscles and potentially worsen a bad breathing pattern as well. But it's suggested that you cover these things: expansion, breathing pattern, and respiratory muscle strength as well. Other things to think about are sleep positions. It's suggested that the sleep position should be such that the spine is kept in a neutral position, and it's better to have firmer surfaces to sleep on rather than too softer surfaces as well. But some of that, I think, may be down to patient comfort. Ergonomics. So if they are sitting at their desk for periods of time, you need to pay close attention to their positioning, because if they are in a very head forward kyphotic posture, which we see classically with computer workers and people on their laptops, then that's not going to be so helpful. And when they're watching TV in the evenings, if they're sitting on the sofa in a curved, slumped flex position, like so many of us do, that's not an ideal position to be in. And they should probably, and it's been suggested, and I've suggested this to some patients with this condition, that they simply spend some time lying on their bellies, up on their elbows, or with a cushion or two, lying in prone, which puts their spine into more of an extended position rather than a flex position. And that's all they have to do, is lie there and watch telly in that position there, so that they don't habitually sit in a flexed position, which could be quite tricky for them. So just a few things to think about. However, some things that you may not have thought about, and some things that I've come across over the years and have been challenged by, is to think about the age group. All right, so we've got teenagers and early 20s, a very body conscious, self-conscious age group who have recently gone through some bodily changes, increased growth, females as well, changing shape, and the cultural pressures, social pressures. So if you tell your patient to stand up straight and sit in straight positions and, talk to them about posture, etc., one of the things we need to be conscious of is that they may habitually be stooping slightly. They may habitually be pulling their shoulders in a bit, not because that's more comfortable for them physically, but because it's more comfortable for them in social circumstances as well. And I've come across that with some patients. Now, there are challenges with the condition itself. It's not just a physical condition. It does have an effect on the whole person. So these are the things we didn't cover today. One of them is medical management. We're going to want to make sure the patient is correctly managed with the correct medications at the right time. Maybe they're taking too much of something. Maybe they're not taking something. Maybe they need to take a medication. So there's a good place here for medical management at the right time. Also, psychological support. I've just mentioned about the sensitivity of the age group that often experiences this condition when it first starts. But psychological support for any chronic condition is also important, something we didn't get to cover today. And also social support networks. There are some great websites out there. It's not really the social support that I was looking for, but there are also support groups, and often groups linked to hospitals as well. So there's this social interaction and motivation between patients as well. So those types of things I think are really, really important, but something we didn't have time to cover today, as we mainly focused on the physical elements. So that's all I had to go through. Thanks for coming. Thanks for listening. And we're not going just yet. I think we've hopefully got time for a couple of questions.
Yeah,
how are we doing there, Mike?
A bit of a to and fro with Karen. I think Karen suffers from AS by the looks of things. Been struggling with lockdown, not being able to do usual kind of routines. So it's been interesting just listening to or reading some of the things that she's been doing. So she's been using the roller, foam roller and weights. Hydrotherapy is best for her, and I think that's that's something to really think about, because obviously you've shown a couple of examples of some exercises there, but obviously you need to be very individualized with the kind of exercises that you do. We've got a patient in the clinic with AS, and we've experimented with loads of different ways of helping to keep his thoracics mobile. And not just because I work with Rock Tape, but the stick mobility stick has been brilliant for him. It's worked really, really well. And when he actually lives on the same street as my clinic, so when we had lockdown, I left him one of my stick mobility sticks, and he's had it all locked down to use at home. Yeah, if you've not used, I mean, you can use other things as well, but what we like with the stick mobility is you can get into all sorts of kind of rotation, flexion, and extension with the stick, and then contract against it, and that's worked wonders for him.
Brilliant.
He's really like that. So yeah, if you've not seen that before, then have a look at that on the website or the YouTube videos, because there's loads of stuff with stick mobility. Might be some. Did Rob do? He did an Instagram live, didn't he, the other day? He did some stick mobility?
Yeah, he did. Examples? Yeah, he did some stick mobility. Yeah, I think he damaged some of his furniture in his house. So I'm not sure. He found it quite challenging doing the stick mobility. and Instagram Live, and in his house. But yeah, Rob's brilliant at stick mobility. He's one of the main instructors for it. So yeah, absolutely. Have a look at Stick Mobility, guys. Stick Mobility UK or Stick Mobility on the internet, the website, and on Instagram as well. You'll see some ideas there for different exercises to do.
And yeah, Ollie mentioned about one of the I guess it's the kind of pullover exercise with a weight, saying that it was a bit high threshold, and yeah, it would be for some, wouldn't it? And so you just adapt it if they struggled with it, and like with everything, you would just adapt it to that individual and see how they responded. But with the guy we've got, he has real bad flare-ups, and then obviously periods of remission as well. So in the flare-ups, there's very little we can do with him. But when he's in remission, we do as much as we can. So it is just adapting to that individual.
Yeah, absolutely. Yeah. Dee asked a question about chiropractic treatment or advice against it. Well, I think thank you, Dee, for the question. Chiropractic treatment, a bit like physiotherapy treatment, covers such a broad range of things. But from the research I've looked at, there's certainly a place for mobilization for these patients. I think it has to be mobilization within their range. I don't think it would be favorable to try and force extra range just due to the process of ankylosing spondylitis. And I think also there's an opportunity there to, when you're mobilizing patients, to actually teach the patients the movements as well themselves, because this is a condition, as we've discussed, which is a permanent condition that has to be lived with and managed. And therefore, anything which you're going to do in the majority of cases should be something which the patient can do for themselves, or be part of a process which educates the patient to do things for themselves. That being said, as Karen's mentioned about having flare-ups, something I didn't mention was having a package in place for when those flare-ups occur. And Karen, thank you for giving the information there. Mentioned steroids, but of course there's other things, physical interventions, there's passive treatments, and the support networks as well. So if a flare-up occurs, you also want to have like a contingency plan, so that when a flare-up occurs, you know you've got this medication, you've got this support network, you've got access to ankylosing spondylitis team, you know, with the nurse, with the therapist, or you've got some private providers that you can go and see as well. So I think it's a very good idea and very fair to have flare-up plans in place and ongoing management plans in place, all the while giving the patient the best treatment options and the best self-management options that are out there as well.
Brilliant. Really good. I think there was one other question that we missed, which was about sit-ups. What's your thought on sit-ups? This was from Ray Matthews.
Sit-ups. I need to do some sit-ups. Seriously, I haven't done much. Sit-ups. So yeah, I don't want to kind of be anti any exercise. I don't think any exercise, there probably are some bad exercises, but I don't want to say that. But I will say, from a breathing perspective, if you do a load of sit-ups out of balance with other exercises, then too many sit-ups causing increased tone in the abdominals can sometimes reduce diaphragmatic breathing, because the diaphragm can't move as effectively as it would like to if you're unnecessarily holding tone in your abdominals. That's one thing from a breathing perspective. I think if you do I think if you're doing sit-ups and lots of other exercises, I think generally it means you're moving and you're exercising, and that's going to be, that's going to be better. If you are exercising regularly, there's always going to be scope for improving what you do and for making your exercises more specific to your individual needs and restrictions. But I think generally, if you're doing sit-ups because you're exercising regularly, you're already on the right page. You just might need to make your plan more personal for you. That's my view on sit-ups. It's not really too specific apart from the breathing mechanics. So what do you think, Mike?
Yeah, same really. I think if as long as it's a balanced program, then, and you're not, you're only focusing on sit-ups, then yeah, why not? And as long as it doesn't hurt as well. So if it's not causing any flare-up of symptoms, and it's a mobility exercise into flexion, really, isn't it? That's what it is. And as long as you've as long as you've got that balance in other directions as well, I don't see why not. Yeah, it would never be something that I would include in everyone's program who's got AS, but it may be something that I would do at some point. Yeah.
Yeah.
I don't see why not. Cool. I think should we finish with D? So she's put thank you. I have a client who came to me just before lockdown, had one soft tissue treatment with them, and have given him thoracic release work and exercises, which includes the ones you've suggested. Oh, very good. He's also seeing the chiro, has been through and has been through lockdown. So I just wanted to understand how that fits in. Right. Okay. Fine. Cool. Yeah. Good. Brilliant. Thank you, Dan. Thanks for that.
Great. I've just put up just to finish off, Mike. I've just put some spinal education videos that I've got on the channel, and some of them relate to some spondylolisthesis and spondylitis and so on. So there's some of those videos to answer those questions on the Physio channel, which I just posted and put as a sticky message there for people. Just wanted to say that. Thanks, Mike.
Brilliant. Thanks, Dan. And thanks everyone for your questions. I think we did, like I said at the beginning, we did this in response to somebody that wanted to learn a little bit more about AS last week. So if there's any conditions that you'd like us to cover, anything that you want to know a little bit more about, then please let us know in the chat box or on our Facebook pages. So got Movement Therapy Education and Dan's the Physio channel. So if you want to follow us on there and pop any questions in there, that'd be great. It's Dan flying solo next week. I'm off next week. I know. Good luck. Yeah, I'll be back in 2 weeks. Dan's back next week. So next week at 8 o'clock. Thanks, guys.
Thank you, guys. Thanks, Mike. Cheers now. Dan. Bye.